everybody to today's webinar on device selection in the ICU. I really am honored to be here with each of you today. We have 500 people on this call, and we really thought it was important to discuss this topic because of where we are with COVID, but really synthesizing how device selection in the ICU is always thought through, different algorithms and different evidence that we use. I do have lots of pieces that I have with me today, a few articles that, so as I do and go through the slides, I'm going to reference some stuff so I can give you really the best direction. I do also have some poll questions that I mentioned before that are embedded from Ava, just to see, how we're doing as vascular, actually that's specialty in the field, especially in this crisis mode that we're in a little bit in COVID. I also recognize that not all hospitals are in the same phase of COVID, and device selection in the ICU remains essential, regardless of whether we're in a pandemic like we are today or whether we're out of it in 6 months. So from my heart to yours, we think about all of the frontline workers every day, and we thank each of you for your service that you're providing to these patients. So with that, I'm going to get started. Oops, I'm going to have to figure out how to adjust my slides. Sorry. Okay, so my conflict of interest, I am an employee of Teleflex, as Blake said. I am the Global Director of Clinical Medical Affairs for the Vascular Business Unit. And my entire focus is really on clinical education and patient safety and ensuring that patients don't have harm related to catheter complications. All right, so here are my learning objectives, really to review the current evidence that applies to device selection. We're going to talk through each type of device to ensure that we're considering each and how they fit into the continuum of care within the ICU. Consider factors specific to the critically ill patient population. Some of the examples that you may think of in your daily life today in those critical scenarios will be really applicable to this webinar. And please, through the webinar today, if you have a question, write it down or put it in the text to question box, and we will do questions at the end, and I'll stay on as long as I need to ensure I have answer your questions for you. Identify proper device selection based on the patient's needs. Patient's needs are ever changing, and we need to understand that, and some things that we may need to consider that maybe we didn't have to consider before, and understand the importance of ongoing assessment of the device after it's inserted, such as when it should be removed. Because device insertion and removal both have a very important part in patient outcome. Just as a reminder, this is really a webinar for learning, and you should still look at each of your product IFUs and your procedural and your policy, your workflow, your algorithms that you choose in your hospital when making clinical decisions. So this webinar is not to direct you what to do. Your hospital policies really should do that for you. All right, so patient populations at risk. So some of the things that we need to identify in regards to intensive care unit is the diversity and the diagnosis of the patients that are within those units. Their diagnosis could lead to outcomes for specific devices that you don't consider, that we need to consider. And I have a list of diagnoses that we're going to go through this presentation, but many of those diagnoses live within your acute ICU patient population. And I also think it's important that when we look at the risk factors for the patient population, such as diagnosis, we also have to look at the area in the hospital in which they're in. So if your hospital has a high acuity surgical trauma, post-transplant, all of those patient diagnoses or those patient groups have a higher potential and a higher need for vascular access, therefore adding potentially to a higher risk. Previous medical history is also one, especially in our renal patients and patients who have had devices prior, patients who've had infections prior, and patients where we're replacing devices potentially because they were not working. All of those patients through the literature have higher risk. And I'm going to say through the literature a lot in this presentation, and what I just want to share with you quickly is on Google Scholar, because of COVID-19, all of the literature related to COVID, and as I talk or answer some questions that are embedded through this presentation, all of that literature is open access and free to you. So I encourage you, I'm going to talk through some publications, but I encourage you to seek publications that are specific to your hospital, to your patient group, to your patient diagnosis group that you're seeing. Not everything is going to be applicable to every hospital. All right, so comorbidities, if the patient has, the more things they have wrong with them, the potential is that the more risk they have. So we device select based on that. Sometimes even the patient history, I go back to acute renal failure or end-stage renal patients who we put specific IV type catheters in because that's all we can put in them to reduce their risk or maybe preserve their anatomy for something longer term. Multiple dwelling catheters, I'm going to talk about a little bit, especially as I review a little bit of the research. We as vascular access specialists have to identify with the fact that each catheter lumen that we choose to place in a patient has an opportunity to have benefit to the patient, absolutely benefit, but it also has opportunity to have risk to the patient. And I will talk through some of those risks and some of the things that we should be identifying as these catheters are dwelling. Frequency of catheter access, we talk a lot about different types of peripheral access to include the arterial catheter. The arterial catheter is the highest manipulated device in the intensive care unit. And it's that risk of those number of manipulations that we have to identify with to ensure that is the catheter clinically indicated? Can it be removed if it's no longer clinically needed? And how many touch points some of these devices that we place in our patients have. And this goes back to the recommendation from multiple organizations to limit the number of lumens that we place in patients to reduce the number of total manipulations. You can equate those to each other. Emergent placement lines are another one of those patient populations. So we used to place emergent catheters in the emergency room, and we would replace catheters when they would come up to the ICU. So remember, we're talking about device selection in the ICU, but think about in your last day that you worked in the ICU, the last time you went to put a catheter in a patient in the ICU, where did that patient come from? Because it's rare that the patient's directly admitted to the ICU from another facility. They're coming through the ER with multiple devices. They're coming pre-hospital with multiple devices. Or the presentation may be that you are called because they attempted to place a line and they couldn't place a line. Therefore, now you are being asked to do that. In the emergent population, this is referencing central venous catheters or peripheral IV catheters that are placed under non-aseptic technique. So if they are not placed properly, they're not secured properly, we would then replace those. There's other options now, such as interosseous and ultrasound-guided peripheral IVs, and we're going to talk through those to limit the risk of this emergent placement. Length of therapy, we'll talk about that, so I'm not going to dwell on this one because we really should device select based on the intended need. In the ICU, what we have to understand as vascular access specialists is that that need changes and that need may change daily. So we'll talk through a couple scenarios as to how we can add additional catheters or remove catheters and how that may work. And really, if it's no longer clinically indicated, when that needs to be removed. And then the last one is the potential for microbial colonization. So I do believe there's a question embedded in the deck for you, but each catheter, each piece of plastic, each lumen has the opportunity to seed a new device. For example, if you place a brand new double lumen PICC line in the right side and you have a 22 gauge in the hand or a 20 in the thumb or the wrist, those other types of catheters that have been indwelling that may or may not be functioning have the potential to seed other devices. The other thing that we have to think about is the recommendation for protected technology, and I'll go through that a little bit closer to the end of the deck. All right, so some of the current evidence, and we've had some new evidence come out in the last few days, so I'll share that as well. So the infusion therapy standards of practice is really what we guide around how we treat vascular access, how we identify what we're held accountable to. This is going through an update right now, so we will or should see an update coming in late 2020, 2021. The Associations for Professionals in Infection Control, also known as APIC, they also influence a lot because they work directly with the National Healthcare and Safety Network related to standards and evidence, and they're really looking now in relation to short-term peripheral IVs, and I'll talk a little bit about that through the research. One algorithm I think that's gained a lot of traction, thanks to Dr. Chopra and the Michigan team, is the MAGIC guidelines. And really the MAGIC guidelines help to facilitate appropriate utilization of peripheral and CVAD catheters, especially when it was being ordered by one entity and inserted by another. So it gives a really good structure in facilities who didn't have an algorithm in which they used, but they had a lot of physician-driven ordering, which is fantastic, but a lot of the times for the longer term devices, the physician isn't the inserter. So it really helps to add some guideline there. If you don't have that, definitely there's something, so all of these you should have as a reference. SHEA, or the Society for Healthcare and Epidemiology, has also did a publication, a compendium in 2014. I'm going to talk through a little bit about that through the presentation. The CDC, remembering that the CDC the guidelines are from 2011, and the CDC really isn't going to do another update unless there is specific evidence related to a section that will be updated. So I think what their plan is that they're going to do section updates moving forward. The Kadoki guidelines were just updated, so if you have not received those, they are freely available online, and it's a 2019 edition, and it has some specific requirements around vascular access, PICC placement, etc. So that's good. And the last one that's not on here is the Gavicel guidelines. So Gavicel, hot off the press, just published 3 days ago or 4 days ago. Read through each of the guidelines and understand how they apply to your organization, because each of them have a little bit different twist, and it's helpful to read the evidence that supports how the guidelines were created as well. Okay, Blake, I think this is our first poll question, hence the IV poll.
Oh, I love it. That's perfect. All right, so we're going to launch this next poll. What type of vascular access device do you insert most often? Early out the gate, looks like peripherals are taking the lead. Peripherals and ultrasound IVs. Okay, we're about at 62%. We're going to close the poll. And this is what we got. So yeah, peripheral IVs, number one at 37%, ultrasound guided IVs at 32%. Like to see that.
Right.
And then PICC lines, second place, the next 20%, and then midline catheters 10%, and your short-term central venous catheters at 1%.
Great. I really think, for this poll question specifically, we do a lot of peripheral IV. That is the main stake in vascular access. It's the first thing that we get. And what we're seeing now through algorithms and through evidence is the emergence of ultrasound-guided peripheral IVs. And that conjunction, either being an extended dwell type, longer IV catheter, or a short peripheral IV catheter, paired with the clinically indicated devices, and that changeover have really changed how many midline PICC lines CVCs are placed, if not clinically indicated. But remember, anytime an actual central line or CVAD type catheter is, those other devices would definitely be more beneficial to the patient. So always on what's clinically indicated and relevant for the therapy of the patient. Great. Thanks, Blake.
Welcome.
Sorry, I'm just moving my screen. Sorry. Okay, so now we're going to talk about, I think that leads really good into device selection. And device selection, when we talk about it, especially within the ICU, is divided into two categories. And it's actually divided into two categories regardless of whether you're in the ICU or not. There is peripheral access and there is central access. And I'm going to talk in depth about a few of these categories as we move through this presentation. But peripheral access includes several devices. So I just want to make sure that we talk through this quickly, and then I'll move forward. So peripheral IV is that short-term peripheral IV. The extended dwell peripheral IV is a longer type IV catheter. It may be an all-in-one, meaning a needle over wire, etc. An interosseous device, and to fully understand where your patient's coming from. Go back again to the day in the ICU, the last time you were there. If it's emergent, urgent, if we don't have access to ultrasound, if the patient is a difficult IV stick, the best solution for the reduction in delay of therapy and immediate ability to hydrate and give medication solutions would be interosseous. And we as vascular access specialists really need to have that in our toolbox. So pre-hospital receives it, ER receives it, and then we receive the patient into the ICU. In that scenario, it is a bridge so that we have time to gain the right resource, to gain the right person, to get an ultrasound machine, get an order for another device. And it's very important that we understand that lives in the peripheral category. It can have all medications that are peripherally administered, and it's very safe. So again, it should be considered in your toolbox as an option, especially if it's immediately needed. Midline catheters are in and out of trend, and we'll talk a little bit about how those have come more recently back into the marketplace and into the ICU. And then I mentioned a little bit ago arterial catheters. They're much like a peripheral IV type catheter in body design. There are some specific things that make them peripheral arterial catheters versus a peripheral IV, such as the body, the strength, the reinforcement of the catheter itself. And remember, all of these devices, I would say, in the peripheral category really have a high manipulation rate, if you think about it, over the time in the ICU. On the opposite side, and really the delineation between what goes in the patient and what doesn't, is what medications are required to be given. And the central venous access catheters, or what we call CVADs, should be considered when the patient requires those therapeutic agents that cannot go through a peripheral device, or when we're doing vessel health and preservation and trying to preserve an entity in the body. And those include your CVC or CICC, your PIC, your tunneled catheters, ports, dialysis catheters, whether they're short-term or long-term, and then sheaths. And when I talk sheaths, I mean the cortices or the sheath where the maybe your pacemaker lead may go through, or your Swan-Ganz catheter may go through. And I mention these to you as vascular access specialists because sometimes we aren't the inserter of that sheath, but that sheath is a co-contributor. If we're looking for how many lumens the patient has, are the lumens idle, is it clinically indicated, can that come out, is it a source of infection? So just making sure you have a full understanding of these different these different device categories, whether it's peripheral or central. Okay, so now let's talk more about the peripheral IV, because I think through the question that we just had, most of you place these, very confidently place them. Some of you have transitioned to ultrasound guided PIVs, and some of you have transitioned to midlines. And all of these really are still in that peripheral category. So a peripheral IV, some considerations, right? And I talked about this already through central access versus peripheral access, is really the infusate characteristics. And this is where sometimes as a team, whether you're on the vascular access team, or you're on the SWAT team, or you're on the ER, or you're on the transport team, it's the infusate characteristic that will determine whether you have a catheter that dwells for the period where you expect it to. For example, an irritant or vesicant or an osmolarity extreme medication, we have to identify with those characteristics of the medications so that we can ensure that we select the right device. So each of these, for a peripheral IV, have an opportunity, depending on the characteristic of it, to harm the internal intima of the anatomy on that short-term peripheral IV, and then we would routinely be placing peripheral IVs. And I always say, people say to me, we gave this medication and within 4 hours I had to replace the IV. And the first thing that you should think as a vascular access specialist, an IV nurse, anybody who works in the ICU, and you're being called back to place another catheter, is what they gave through it last and what the characteristics of that are. You can reach those characteristics through your pharmacy, but most of the hospitals have it on their med profile where you can put that in. Sometimes you can alter those characteristics to suit the device. So collaboration really is key, because we still probably insert more peripheral IVs than any other device. The duration of therapy is important, and a lot of us have moved to clinically indicated device insertion removal. So this actually has a bigger impact on our healthcare system or organization than we think, because if you've moved your duration of IV therapy, 2 years ago, it was 72 hours. By a show of hands virtually, just kidding, how many of you are still changing it at 72 hours? Different pockets of the country are still doing that. The people who have moved to a clinically indicated dwell, there's more education, more awareness, more accountability, and more assessment required of those devices, because now you're leaving something in to dwell longer, and the risk might be heightened, especially if the insertion technique or the area of insertion wasn't appropriately selected. And availability of peripheral sites is really next, but I want to talk about the publication out of Australia a few years ago that was published about range of motion. So peripheral IV catheters should really not be placed in an area of flexion, right? And it shouldn't be really placed in the hands anymore. We know that, I think you can see me on my video, that we should be putting them in the forearms or further up the arms. And that's really to stabilize the catheter and allow that extended dwell period of time. And you can translate that to other types of catheters that you insert. The more they're in an area of flexion or motion, the higher fail rate those catheters would have. On the question, it was nice to see that a lot of you have moved from peripheral IV, if you can't see it with the naked eye, to ultrasound guided peripheral IV, which I think is a fantastic advancement in our scope. But infrared technology is also a recommendation from INS and other organizations to ensure that we have multiple tools. And multiple tools may mean that the non-vascular access team may be using that infrared tool, or may have their first attempt, and then they call the vascular access team. So we need to make sure that the people placing devices have the same amount of education. Again, PIVs are probably the most utilized device in all the world. So I could talk PIVs for a long time, so I'm going to keep going. So the size definitely matters, right? Size matters. The smaller the catheter, in the more, the bigger the vessel allows for more dilution, right? So as you give these medications, the medication is able to move freely, and we're not obstructing the flow of that anatomy with the catheter size itself. So I always like to think back, I probably have some ER nurses on this webinar and some ICU nurses, and it was like everything was an 18 gauge. If you didn't get an 18 gauge in, it was like you let something down. But we really are going more 22s and 20 gauges to ensure that there's enough flow around the outside of that catheter so that we're not causing harm to that patient. And then contraindications, obviously, continuous vesicant. There are some publications about different types of vesicants. I encourage you to look those up if that's something that you're doing. TPN, due to the dextrose concentration, that's obviously needs to go into a CVAD type device. And then infusates with an osmolarity of greater than 900 milliosmoles. The INS standards did take pH, specifically only pH, as a requirement out of the guidelines a couple years ago. And people should still be monitoring their device failure specific to PIVs, because that change was just made within the last couple of years. Okay, so this is a really interesting publication, and I will say to you, if you don't have this, you should. This is Christopher Kovac's study from 2016. This is a publication that should be under your pit cart, under your line cart, in the ICU, whether you're on a vascular team or whether you're on infection control committee, etc. So COVAC, and I have notes here because this is such a good publication, but COVAC looked to see, based on the National Health and Safety Network's definition of CLABSI, he looked at a sample of patients within his hospital, understanding that Staphylococcus aureus is the highest infection rate known within the healthcare organizations, meaning it's hospital-acquired bloodstream infection. And he looked at specifically patients that fell into the CLABSI category by definition and the non-CLABSI. And what that means is either they had a central line and they met the criteria of the National Health and Safety definition, or they did not have a central line and it was considered non-CLABSI. So I want to read you some of the numbers here from this, and please pull this publication so that you can read it. But how that 64% CLABSI versus 36% non-CLABSI is calculated. So basically there was 122 patients in the sample. Okay, so 122 patients, they identified a primary hospital-acquired bloodstream infection. Now I'm just going to talk for a second about the non-CLABSIs. There was 78 patients total in the CLABSI group, which was that 64% that you're seeing on the slide. There was 44 patients in the non-CLABSI group. So if you want to take a pencil and make any notes, I'll give you just a second. So 78 patients, or 64%, were in the CLABSI group. 44, or 36%, were in the non-CLABSI group. So the total sample again was 122 patients. So in the non-CLABSI group, 44 had that primary bloodstream infection. 26 in the non-CLABSI group had a documented PIV infection. 19, or 43%, of those occurrences occurred in the intensive care unit based on patients that were in the ICU. And 27 of those 44 non-CLABSI grouped patients ended up requiring admission into the ICU because of the primary bloodstream infection and had an IV in place. So going back to the question I asked you earlier, what devices are we currently placing? I didn't ask you how you're placing them. I didn't ask if it was sterile insertion technique, if you were using a probe cover, etc. But this study right here will help you and your administration determine what your best quality initiative might be. And this is where it gets important. We track CLABSI, right, because it's reportable. But really, COVAC and colleagues recommend that every infection be tracked so that we can really reduce hospital-acquired infections holistically, like all of them, not just based on one type of device, because we're definitely a little bit underreported, and that's in multiple publications. So the 30-day and 1-year mortality did not differ between the two groups. So I think that's important. The complications, though, in the non-CLABSI group were more significant, that they also required more surgical intervention, and that may have been from compartment syndromes, etc. But again, read that publication. And then the relationship between PIVs and midlines and nosocomial, where he identified with his colleagues what he thought the issue may have been, was emergent insertions, because an IV, 20 years ago, we maybe didn't think was the most important thing that a patient's getting, but it certainly is. Longer dwell times, because we're extending the dwell time now. Questionable IV sites, because we keep them just in case we need it in the future. And then inadequate care and maintenance. And I think as vascular access specialists and IV teams have really taken ownership, we've solutioned some of these things already. But again, it's a great publication and definitely worth the read. Okay, Blake, there's a poll.
Oh man, you've got some good polls. All right, let's see here. I'll launch this one. Has your institution increased the use of midline catheters as a risk reduction strategy? Yes or no? And I don't think that's necessarily in conjunction with COVID. I think this is a generalized statement for historically. Correct, Amy?
Yeah.
All right, let's close the poll. And it's looking like split down the middle.
Good. So we didn't have, I think we had about 10% placement of midlines when we did the original question. And this is good. So I'm going to review midlines next, and we'll see how the midline contribution to the care continuum has changed a little bit through not just COVID. I don't even think this is related to COVID. I really think this is just in practice. So midline catheter. So the consideration really, again, is the medication infused aids characteristic. So that is, again, the peripheral, anything that can be given through that peripheral access. The duration of therapy, these could be potentially in longer than a peripheral IV, and because of the nature of their material, the insertion technique, and the catheter body being more flexible and less rigid, they may perform better over time. So important to understand the characteristics when seeking one over the other. What comes to mind is the bariatric patient population, where you have a lot of adipose tissue, where, you know, we have these new extended dwell type catheters, which are longer, in a sense, peripheral IV catheters with the same type of body as a peripheral IV, where a true midline catheter, because of the nature and the anatomy and the body habitus of where we may place these, maybe in the upper arm, they go in a little bit deeper, and the body makes that contour, you know, making that contour with the polyurethane type flexibility, it allows the catheter to last longer. Definitely can infuse everything that you would infuse through peripheral access here. I think one of the main topics really here is it should not be used as an infection prevention strategy. You know, we talked a lot about intensive being in the ICU, having some reportable metrics, doing the right thing by our unit based on reporting. And what we have seen, you know, throughout different areas is less central access. Definitely, if it's not indicated, don't put it in. But switching automatically to a peripheral or to a midline, and to the point where I would have clinicians say it is hard for us to get a CVAD type catheter ordered because they really want us to exhaust everything first. And if you go back to that COVID study or COVAX study, you really should do earlier intervention of the right device versus potentially contaminate the patient through multiple devices first. So contraindications, again, are same with peripheral. So if you do continuous vesicant therapy, you wouldn't do that through a midline. If you need nutrition, again, and if the infusate is greater than 900 milliosmoles, you still, again, want to use something that's more centrally located. This would be considered the same even if it was a short period of time. You really don't want to disrupt the intima, that first layer of the venous anatomy, with that vesicant or that caustic medication, because you may limit access in the future. For midline catheters, you really want to avoid patients with history of thrombosis, because these do tend to have a higher rate. And I say that because that's based in the literature. But when you think about where these catheter tips reside, they're in a very static area. A CVAD is central, right? It's in the central circulatory system, and it's like a toilet bowl, and it's flushing, and everything's moving rapidly. When you have a midline type catheter, it's in the upper portion of the arm. And in the upper portion of the arm, depending on the patient position, the size of the anatomy, and the catheter vessel ratio, you may not have a lot of dilution around the tip of that catheter. And then to be really fair, as vascular access specialists, we put the lines in, but that doesn't mean we're giving the medications and the therapies through those devices once they're in place. So we pick the device based on what we know right then. That doesn't mean that therapy might change, and they may not call you to alert you of that change. The last one's really end-stage renal disease. They really trying to not place midlines in those patients. And again, refer to those Kadoki guidelines that were just updated in 2019 for that. Oh, Blake. Poll question.
Just keep them coming. Those polls are great. All right, next question. During the COVID-19 crisis, what type of central access is being inserted the most in your ICU? Let's see how this.
So Blake, while they're answering that, I'm going to explain my polls. So the last poll was the North Pole, meaning peripheral access, and this is the South Pole, meaning central access.
Love it. It's perfect. All right, looks like we got over 50% here. Let's close the poll. Those results are, so central venous catheters, your centrally inserted central catheters took the lead, 69%.
Yep.
PICs coming in
Okay.
second.
That's fantastic. I do think that's the right device for the acute presentation of the COVID patient, and I am going to talk a little bit about those next. So CVAD access is that short-term acute central venous access, whether it be tunneled or non-tunneled, and when it becomes that tunneled catheter, that's the difference between long-term and short-term, right? In the COVID scenario, to elaborate a little bit on that last question, we're seeing a lot of occlusion based on some of the research that's coming out from the hematology different sections. So the International Society of Thrombosis and Hemostasis is, doing directives on how to anticoagulate patients because what COVID is what's happening to the bloodstream of the patients is whether it's cell damage or lysis or increased iron in the blood or just the fact that the patient is very hypoxic and it's making the blood very tacky and sticky. We've had, colleagues and peers, especially on our Facebook group, different avenues that we see things, peripheral device failure in some of these ICU patients. So it's important that device selection is appropriate. I'm glad to see that most of those devices are acute central lines. So some considerations for these: so minimize unnecessary CVAD placements, infusion regimen. So what you're giving through it now, you now can give a vesicant or an irritant, you can give chemotherapy, you can give TPN, you can do your blood draws, you can do CVP monitoring, etc. So definitely different indications for this type of device, a different level of potential risk for this device, but also the risk benefit to the patient, I think is well defined here. You can do invasive hemodynamic monitoring, like I said, whether it is CVP monitoring where you're just monitoring fluid, or whether it might be blood sampling where you're actually monitoring labs. And then the long term, it really is the tunnel type catheter. We're seeing different clinicians placing tunneled catheters because potentially the central anatomy, we can't get to the central anatomy due to positioning, or maybe the central anatomy is blocked on one side, or maybe it's tunneling of a long-term PIC type catheter, and they're so far up in the arm underneath the shoulder that they don't want to be in the armpit. So there's definitely some tunneling going on, and that tunneling category really would be for the longer term patient requirement. Okay, Blake. This one's from Alaska.
Oh, Lord. All right, launching the poll. Are you being asked to insert PICs in prone patients? Yes or no? Are we seeing a lot of prone insertions, Amy?
So for COVID-19, we're seeing a lot of proning, period. Due to the acute nature of the ARDS that's occurring with these patients, especially once they get ventilated and oxygenation becomes an issue, we are seeing more patients being proned, and they're being proned up to 16 hours. So basically proning means that they're flipping the patient totally over onto their stomach. And that is really for VQ mismatch or oxygenation shifting. So the backside of those lungs that have been flat on the bed can now oxygenate. So they're really seeing this quite a bit.
All right, so for the results here, we got 79% no.
Okay. All right, I'm going to talk a little bit about proning here. So for PIC consideration, we have seen a couple different scenarios where they are proning patients, and they're using tip location technology or navigation, and they're meeting the needs of the patient in that moment in time. A PIC is really, again, for that longer term therapy. It goes in vessels in the upper portion of the arm. We really need to ensure catheter vessel ratio. These do have a little bit of a higher risk for venous thrombosis depending on where and how they're placed. And And there definitely are some higher attributions for cancer in critically ill patients. When you think about proning, right, because there's no other device that you really could put in when the patient's prone. So the patient's flipped upside down. We have seen a few PICC insertions inserted with the patient in the prone position. Just remember, if you're being asked to do that, one, there is a moment in time where the patient's not prone, because we can't keep them prone due to just the swelling that occurs in the third spacing and the fluid shifting that happens. So they're not always prone. So they would have a moment in time when they're not prone. So if it's not safe and it's not the right thing for the patient, we wouldn't do this in the prone position. We're also seeing tunneled catheters go in when the patient's prone, using the same types of modalities. But just remember, we have to be able to document assessment. We have to be able to look at the insertion site. But I do understand, as a vascular access specialist, that in the moments where you're making difficult decisions, you're contributing to saving that patient. So all motivation to you when you're able to work outside the box. And some of these policy changes that you talked about in the beginning with the questions may be related to some of this, having to work a little bit differently than potentially we worked in the past. I will, just mention again that the Society for Thrombosis and Hemostasis did recommend the anticoagulation of patients with COVID due to the higher risk of thrombosis. Remember, we went away from Heplocks, from heparinized saline in arterial bags. We just went away from that completely. But when patient presentation is that they are occluding devices, those are the things that we have to revert back to our history and say what worked then. And it may be very scenario-based in your institution, but keep that in mind. If you're new to vascular access, we definitely had ways to maintain patency of devices before COVID, and we can still use those now if needed. All right, so another one is the port. We see, this is from an ICU perspective. We're not putting these in the ICU. Maybe an arm port if you're on a vascular access team that does arm ports. But we're receiving patients with these devices. And I think the gap here really in what my message would be is that we shouldn't be putting additional devices in if the patient has a port. And sometimes it's not until we see the x-ray and realize, wow, what is that on the x-ray? Oh, they have a port. Why do I have an additional order for another device? Each device adds risk to the next device. So just make sure that some hospitals are saying, they don't want their port used because there's not enough people trained how to access or de-access it without infecting the patient or having a complication. It would be better for us as vascular access specialists, especially in the ICU patient, to preserve their anatomy and functionality of their implanted devices and do education related on how to access or de-access, or even better, be that person or that team that does all of that accessing and de-accessing. Just remember that if you take that role on, that you need to train somebody for the times that you're not in the hospital. Because again, I wouldn't want to go in and have a PICC put in if I have a port, but there was nobody to access it. This is a central line. It is considered a central line from an infusate specific criteria. We do have policies and protocols on aspirating it and wasting anything that was residual inside of a port if it's sitting for a long period of time. And there's some guidelines around drawing blood cultures, especially if you think that the patient is presenting with fever or chills, et cetera, into the emergency room or into the ICU. So definitely understand your port patient population that may or may not come in or flex out of the ICU as well. It's just like one of my favorite subjects in the whole world, arterial catheters. It dawned on me though when I talked on the first slide, arterial catheters. If any of you do balloon pumps or have been involved with balloon pump monitoring, arterial catheters are also what we use for a balloon pump to run those machines. So we should be treating those with the same regards as we treat peripheral arterial catheters. So arterial catheters are a little bit different than a peripheral IV in the fact that we don't give medications through them. We use saline or heparinized saline to maintain a monitoring setup that then leads to the pressure monitor on the screen that reflects a blood pressure. Again, this is the highest manipulated line in the intensive care. And if you can see my hand, because we become the experts of vascular access, even devices we may not insert, insertion in the range of motion, like we said about the IV, inserting an A-line in the range of motion area 2 has a high fail rate. So you really want to encourage the inserter, or you as the inserter, to use your ultrasound and really move down the wrist to ensure that you aren't mechanically complicating that device just after insertion. So 1, it requires a monitor. 2, we draw blood from it all day long. And right now during COVID, they're doing a lot of blood gas analysis for these ventilated patients that they're trying to wean and accelerate extubation. We definitely use ultrasound, and that's that new, the new position statement that came out in this journal edition. During COVID specifically, right? When the body is trying to peripherally shunt, and I think this is probably the most important about arterials for this session, when the body shunts, what happens is it vasoconstricts. And when it vasoconstricts, it basically tries to just perfuse the vital organs. And by doing that, it reduces circulation to the periphery. So if you put a radial arterial catheter in, potentially a COVID patient or a severe septic patient, and their hands are mottled or blue or cold, you really should advise that that catheter be changed to a femoral catheter. A femoral catheter in the arterial will have a true trunk circulation, meaning that it will show a true blood pressure based on the medications that they're giving to try to support overall mean arterial pressure. If you choose to leave it in the wrist and it's cold, it's blue, there's not a lot of circulation, you do risk thrombosis and potentially perfusion issues to the hand. You'll also have the ICU calling saying the blood pressure doesn't match the cuff pressure. So you really want to identify the circulatory mechanism of where the catheter is living. I would also say that to you for a peripheral IV. If in your patient they present very cold, very mottled, you have to understand that there's a slowing of blood flow in that area. So the peripheral IV potential would be the same. Why we see this most in arterial catheters is because they're connected to a monitor, and the monitor tells us right away if there's an issue. Where some of our peripheral catheters, when they have decreased perfusion, we don't see that until the catheter fails. I just love arterial catheters. Okay, hemodialysis. So this is another interesting thing from COVID. So we have seen a rise in hemodialysis catheters. So hemodialysis catheters are a large double bore catheter. They're in the neck, most likely, because if you place them in the chest, they have potential risk for patients who need long-term therapy for hemodialysis. So the primary vessel of insertion really is the IJ on the right side or the left side if required. We do use these to preserve, this is an acute hemodialysis catheter. We do use these to preserve the anatomy for fistula formation or maturation for patients who require long-term dialysis. But in the COVID type scenario, we are using dialysis catheters because of renal failure, right? If the patient goes into renal failure and needs to be on dialysis, then they use an acute catheter because it's an acute injury at the moment. Longer term tunnel type dialysis catheters are placed when a patient has a recurrence and or a known kidney injury that needs a longer time to recover. So you may be seeing this. These are treated like a central line. They're cleaned, they are removed when no longer clinically indicated, and really should follow the same guidelines as your central line. When it says avoid blood sampling, transfusion, or infusion of medications, it's because they're really saving that catheter for dialysis. And if they were to lose access, or if the catheter was to become infected, that patient can't have the dialysis they need to clear mentally or clear their labs required. So that's really why you see some of your renal failure, your renal doctors, they tape the lumens off, they block them off so that nobody can use the device except for the dialysis nurse. We try to also avoid routine replacement of these devices because they're large. They're larger bore, the body's larger, and this potentially could cause venous stenosis. So we try not to replace those routinely if we don't have to. There is some salvage therapy in the INS guidelines related to blocking and packing these if they were to formulate a thrombosis or occlusion, so that you could salvage the catheter versus exchanging. So hemodialysis catheters have become very important. This is one catheter within the ICU that we still lock or pack with different solutions to ensure patency. And if you're looking at the number of lumens that your patient has in, you should consider the dialysis catheter lumens because it is an idle type catheter. Okay, Blake.
Loving these.
It's hard because I'm used to looking at people, and I'm not looking at people, so go ahead.
All right. Do you use a device selection tool? I know there are some people out there using like the Magic Guidelines app, and maybe just have that as a reference as part of their unit, or maybe they have it in their policy as far as how they've built their tool into practice. And I want to say one of my colleagues had mentioned that they're actually building like the Magic Guidelines into EMR.
Mm-hmm.
So
yeah, actually some hospitals have built into the EMR, whether it's Magic or whether it's another algorithm that they've adopted, they have built it into the order set. So when the physician puts in the order, they actually have to justify the requirement for the device because they're doing that risk benefit ratio within the EMR, which I think is outstanding.
Yeah. All right. So the results here are split down the middle, 48 and 52 for yes and no.
Yeah. So this may, this may be contributed to the first answer, or the first question we asked about what devices you place most, because really the device algorithm is for peripheral IV access, but it really is what's next. It's that, do we need to advance it and to put another type device in, another device that has a higher rate of risk? So that might be why we're seeing a 50-50 split. My recommendation really is, if you do not use a device algorithm, that you identify with one. And I'm not saying go out and get a whole bunch of things to fit into a device algorithm, but take some of the decision trees that are out there freely available to you, and go into your supply cart or your vascular access team stock and say, okay, what of my devices fit into this device decision tree, and is this something we want to adopt? So this is a basic device decision tree, and it really says, first and foremost, the patient requires IV therapy. Does it have an osmolarity less than 900 milliosmoles? Can it be given peripheral, or is the osmolarity greater? Is it considered a vesicant irritant? And does the medication need maximum hemodilution, meaning we don't want the medication to impact the ability for the patient to, the anatomy to maintain patency. We don't want to cause a potential medication-related occlusion, etc. So on the peripheral access side, a lot of IVs again going in. Can we see three or more sites? Can we visualize on the patient that if I had to change IV locations, do they have good naked eye IV sites? And I say naked eye, and I sort of chuckle because there's not a lot of these patients anymore. Patients are getting what we call difficult venous access in a higher rate these days. So let's just walk down this: 3 sites or more, yes or no. Is the duration less than 5 days? Is whatever they need less than 5 days? Maintain peripheral access. Great, you have what you need. The patient doesn't need to have any more access added. Is the duration greater than 5 days? And if it is greater than 5 days, or 2 to 4 weeks, when you think about after those 3 sites have been exhausted and it was greater than 5 days, so 3 days, 3 days, 3 days, and you need an actual device for peripheral access for 2 to 4 weeks of therapy based on the antibiotic or the fluid regimen, then that would be a consideration for a midline. If you flip to the opposite side for central access, you're really looking at the mechanism of the device, the characteristics of the vesicant irritant, and establishing that they need central access. And if they need central access, based on duration is how you're going to then select what they need. Is it short term or is it long term? And based on that discussion, it can help you with whatever the tools that you have currently in your hospital to decide how you're going to treat that patient that fits that criteria. All right, so now a little bit about different risk and how we can mitigate some of this risk. So patient criteria. So when I say protected technology, we have identified that if a patient is in the intensive care unit or on the floor or requires vascular access for greater than 5 days and meets this criteria, so this comes from SHEA and or CDC and or INS, so that's where these references are coming from. So if the patient, just think about your ICU patient that you were just recently with. Neutropenia, yep, check the box. Transplant, burn, if they're critically ill, that's a reason for them to be in the ICU. If they're receiving chemotherapy, if they're pregnant, if there have been a trauma, history of DVT, if you're doing a catheter exchange, if they've had a bloodstream infection, if the unit that they're going to in the hospital has a higher rate of infection than any other unit in the hospital. And I say that, but when you think about it, you know that that is probably more common, that the ICU, because of the comorbidities, the procedures, etc., the flex in staff, the procedural, the isolation requirements, all of those contribute there. Emergent insertions, again, age extreme, so really, really young or really, really old. We have patients that are living to extreme ages now, so have to consider those. Patients with other vascular access devices. So the recommendation is really that we should consider a protected technology, whether you have an antimicrobial technology, whether you have an antibiotic technology, something to protect the patient. And this one, patients with other implanted devices, really resonates with me, because if they have a hip, or if they have a pacemaker, or if they've had implanted graft, or if they have an implanted stent, anything else that we put in them has the opportunity to negatively impact that implanted device. And we don't really think about that sometimes during the, let's get that line in, that the patient needs this right now. But there are things that we can do, such as device selection, minimize number of lumens, use protected technology, use ultrasound with a probe cover, do a sterile insertion technique, even on a peripheral IV if that's what your hospital's plan is. So there are things that we can do. And the last one is if the device is going to dwell for greater than 5 days, especially in units of high manipulation, such as the ICU unit. Okay, I think this is my last poll, Blake.
Loving these slides. Let's see here. When inserting a new vascular access device, do you remove existing devices? Yes or no? And sometimes. Third option is that.
So while people answer this is important, because if you think about that hemogeneous seeding that occurs when you have a device in situ and you put a brand new device in. For example, when you put a new PICC line in the patient, the tubing has to be changed. The hang solution has to be changed. All the connections have to be changed. We wouldn't attach the old to the new, right? With the vascular access, we have to think of the same thing. We would have to, as vascular access specialists or IV teams, we're putting in the device appropriate for the required regimen of therapy, and we're putting enough in to suit the therapy. So if we do that, and we do that in the most efficacious manner, then the other devices should come out. And when I talk to my peers, there is either a direct connection, they understand that and they run with that, and they'll be able to take those catheters out and they're given that autonomy. But there's others that put the device in and then we have to walk away because somebody else owns that portion. So just reminding you that when you place a brand new device and it has the number of lumens and configuration required for the therapy, anything that's old really should come out, especially by definition if it's no longer clinically indicated or not being used within the last 12 hours. If we're not using it, it should really come out to preserve the anatomy. This may be different. I know some of you are like, oh no, I'm not doing that. This may be different if you have a difficult patient, it was really hard to get, they have to keep it for whatever reason, but we really should be questioning that as we remove and insert devices. And do they really need the new device? We should question that as well. All right, so here's the protected technology device selection tool. So this is a little bit different because we talked about using an antibiotic or antimicrobial type catheter body for this. So non-emergent or emergent. PIV access, no. If they don't have access and it's emergent, again, they should go IO, interosseous. It's quicker. They don't have to use ultrasound for it. It's a bridge so that you can get the right device in for the patient with the right tools and the right resources, and it's buying you time. And then if it's non-emergent, you look at types of infusion, right? Because it's less of an emergency. This is a planned out process, not central versus central, and that's determined based on the medication characteristics really only. That's the only thing that determines that for you. Central medications or non-central, and MAGIC really walks through what those look like, peripherally compatible or not peripherally compatible. Proposed duration talks about the chronic kidney patient and what stage they are, and then what the length of therapy is. So do they need an ultrasound guided IV? Do you need a midline? Do you need a protected midline depending on the comorbidities of the patient? Do you need, in your CKD patient, do they need a small bore central line, or do they need a PIC or a protected PIC? And remember to research those Kudoki guidelines and make sure that your policies in your hospital align with those standards, because that will really help you if you ever have to defend the Y, especially in that patient population. There's an association specifically for them. So these are a couple of the catheter technologies. So in the ICU, we are exposed to a lot of things, and we may see different catheters depending on our organization or institution, but you also will see different types of catheters when you have different strategies in place to reduce patient harm events. So there's antimicrobial catheters, which would include chlorhexidine or an antibiotic. There's antithrombogenic catheters such as Indexo or Aerogard Blue Advance. And I want to stop here about the antithrombogenic, because I am also seeing and getting questions in relation to catheters occluding, but also fibrin sheath formation on the external portion of the body of PICCs and central lines. And the antithrombogenic properties does have a characteristic to not allow fibrin formation to build up on the external surface of the catheter. So really, there are solutions for this, especially in your COVID patients if you're seeing this occur. And then the combination of an antimicrobial and antithrombogenic in the Aerogard Blue Advance type family. So in the ICU, like I said, we see a lot of different catheters, and I just wanted to help you to identify what the color means based on duration and if it's a protected type technology to help you, whether it's thrombotic related or infection related. So this is an acute central line, Aerogard Blue Plus, and blue means that it's a protected catheter, meaning I really have to have you dive into what your own hospital uses, but if the catheter is blue and the body is blue, at minimum, the external surface of the catheter is protected. And protected, what I mean by there is chlorhexidine and silver sulfadiazide. So again, something to help you through care and maintenance and reduction over time, especially if the catheters are going to dwell for any period of time. The black catheter body is it's aluminum, silver, and carbon, and it is non-antimicrobial. And then the white catheter is most of our catheters that we see, and white catheters do not have a protected mechanism. Yellow catheters do not have a protected mechanism. Purple catheters do not have a protected mechanism. You may see some teal catheters, and some of them, if labeled, do have an antithrombogenic type property to them. And then brown catheters have an antibiotic coating on those. So there are different strategies and different colors for each. So just remember to, as a vascular access specialist, we don't have to just know the anatomy and how to use ultrasound and how to device select, but actually what those devices do, especially in the long term, of the patients. So I hope that the color coding was helpful there. All right, so I'm just going to wrap this up with practice considerations. So I'm very excited to know that vascular access teams are recommended by several organizations, including INS and SHEA, that we really should have a dedicated team to help with all these things that I just talked about: the how, the why, the when, the where. Be mobile, be agile, and be available to help, especially in upticking utilization of different technologies, ultrasound, protected catheters, all-in-one devices. Really, we are the teams that are available to do that. And then use of ultrasound. There are many more agencies that are listed here that have and advocate for us to be using ultrasound for all of our device insertions. We know it increases first-time success, and we know it reduces harm to the patient. So please ensure. And then, just again, this edition of the JAVA magazine has the ultrasound and the vascular access specialist in it as well. So please use it. And it has additional resources outside of this slide here. And then additional considerations from SHEA. From a COVID perspective, excuse me, when you go into a room and you're full of all your PPE and you're doing a sterile procedure, today more than ever before, using a standardized process. I know we have insertion carts, I know we have trolleys, we have different modalities that we use, but having everything together in one area makes us as clinicians very successful. And having to go outside the room, if you can imagine that right now in some of our crisis scenarios, to go outside the room to get something that we forgot would be another hour delay of therapy to the patient. So really, the CDC and SHEA for many, many, many years have said, have everything available to you to do the right thing the first time, and also try to have it set up in a way that it allows you to be successful and to remember the steps, because sometimes we don't do a number of lines for a period of time and it's like, oh, yep, this one, then this one. I know that sounds weird, but human factors do come into play, especially the higher the stress situation. So catheter vessel ratio is important. In the naked anatomy, especially in the periphery where you would normally use a tourniquet, we should be trying to measure with and without a tourniquet. Tourniquet really stabilizes or engorges. That's the two rationales for a tourniquet. But when your catheter goes in, especially in the periphery, whether it's an IV or whether it's a PIC or a midline or an extended dwell, that vessel is going to be much smaller without the tourniquet 100% of the time. So try to use, do all of your measurements without a tourniquet to ensure you have that less than 45%. That is the guideline right now. And you should be documenting that guideline to look at thrombosis or impacts related to devices that you insert. Remember, those things happen 2, 3, 4 days later. So really doing some good assessment and documenting your catheter vessel ratio on insertion. And then ongoing assessment. Again, in the ICU, we are the inserter, right? That doesn't mean we're always the one doing the assessment, the device removal, the rounding, but we should be engaged because you're going to get called if there's a problem with the device. So multidisciplinary rounding on each device. Can it be removed? Is it clinically indicated? Can it be downgraded to something else? If it has multiple lumens, do they really need all those lumens? Is that a risk benefit? All essential catheters and non-essential catheters, should be removed, especially if you think about transition from the ICU to the floor. So when you put a central line in, or you put multiple IVs in, and then you transition the patient to the floor, they may not be normally used to taking care of an acute central line in the neck. That may dwell just because there's not comfort with removing it. So really understanding that those dynamics in your institution, especially right now when we're using multiple disciplines from other areas of the hospital to treat patients that are critically ill, and we're fast training people to really help with these patients as they migrate out of the ICU, just making sure that those devices won't add or contribute to risk later on in their stay. And then ultrasound. So we use ultrasound for insertion, we use ultrasound to measure the vessel, we use ultrasound to justify the vessel. We should also be looking at it for assessment for catheter-related thrombosis. symptomatic or asymptomatic, and listening to the patient. Do they complain about the insertion site? Do they say it's hot, warm? Thinking of those early intervention signs so that we can really help with solutioning those for the patient. And then one of the things that we've really done well, I think, as we started to use ultrasound, use it throughout the entire care plan. So if your IV isn't working, put the ultrasound on where the tip of the IV would be. Is it the catheter or is it the vessel? And that's really important, especially if you think that maybe a medication that shouldn't have gone through the peripheral IV did, or maybe the patient has multiple IV failures. Ultrasound the tip of the catheter and see what's happening. If you have a midline and you can't draw blood, ultrasound the tip of the catheter and see what's happening when you try to draw blood. It's not a sterile procedure anymore. This procedure's done. You're simply using the probe distal to the insertion site and looking. Arterial catheters would be the same. If all of a sudden you lost your blood flow, you couldn't get blood flow out of an A line, check your tip of your catheter with your ultrasound. It would be really good forward-thinking troubleshooting that you could do. All right, here's my conclusion. So current standards and guidelines help determine appropriate device selection. The ICU is a little bit, it needs a little more diligence. It needs more attention. It uses larger devices. It needs more people in the care plan. Critically ill patients have a lot of risk to consider. So looking at the entire picture of the patient and also forecasting what you think they might need, that would be very helpful. If your patient's not in renal failure, but they're borderline in renal failure and they have a central line ordered, it might need to be a dialysis catheter or a triple lumen catheter instead of a central line. So really be thinking about those characteristics and scenarios. Device selection should include risk to patient benefit, and I think of proning a patient and putting a PICC in this scenario. Can you do it? Yes. Should you do it? Depends on the scenario, your skill set, your resources, and how often they're flipping that patient back over. So go forward and do these things, but remember to think how you're going to do your assessment, how you're going to identify catheter vessel ratio, but also think about the fluid dynamics and the fluid shifting when you turn a patient front to back and what pressure might be put on that device, and it may or may not influence the performance of the device. A decision tree or algorithm can assist. Please download one, see one. There's some good ones out there that you can really add to your hospital policies or practices. And then post-assessment aids and identify of catheter-related complications such as use of ultrasound, scanning, listening to the patient, not just doing the device insertion, but actually being part of that device throughout the entire continuum of care. So thank you very much.
Awesome, thank you, Amy. Questions and answers time. I'll put my webcam back on.
That was a lot.
We're back. So great questions, guys. Just reading through here, we've had some from all the way back in the beginning of the show here. Let's see. See if I can pull this up. Need guidance on the best way to place a PICC when the patient is in a COVID positive pod that houses 3 patients on ventilators and there are no doors to section the patients behind for CLABSI prevention. So any suggestions as far as how that would operate? All
right, so I'm just going to visualize this. There's 3 patients in one pod, there's one room, they've confined them all together. So you're going to do your PPE, you're going to prep and drape the patient, and you're going to place the device under your sterile technique and document the environment. There's nothing else you can do. We can't move the patient. We can't isolate or bring extra equipment in to block off the other patients. You're going to do the best that you can. And you know, think back of when we did mobile insertion, bedside to bedside, and 2 people were in a room. There was only a curtain between the insertions. So do your best and isolate. There shouldn't be any I'm sure there's no fans or air, weird air blowing. So as long as you prep and drape effectively, I think that you're good. Make sure that you document it though. So if something does come up related to infection, that you can justify the why.
Next question here. In light of COVID, do you think short-term central access, IJs or subclavian lines, should dwell longer before changing it out for a PICC line?
That's a good question. So currently your IJs and subclavian lines, if they have a protected technology, can dwell for up to 30 days. So there is no reason for you to rush to change that device to a different type of device if not needed, especially when there's so many other things going on with that patient and access is everything. So extend it. I know some hospitals change devices every 7 days because they've always done it, but that's not something that you have to do. So just look at your product IFU to ensure what you're using at your facility.
Thanks, Amy. Question for you. I'm going to pop in now that I finally got my mic to work. So a couple of questions that I actually had texted to me versus on the screen. People are starting to use some products they haven't used before as add-ons, as in tissue adhesive, sub-Q, securement. They've seen. What are your thoughts with those?
So I think that we have to use the best resource that we have within our healthcare institution to maintain our lines. So if it's one, stopping the bleeding, or if it's stopping the adding pull strength or pull force to the device, we've gotten very creative. Think about the IV poles outside the room. Did we ever think that we would put an IV pole outside of a room that has multiple extension pieces that's connected to a central venous access device? So I do believe that hospitals need to be directed to use the best, safest, but also they need the education to use those appropriately. And it's hard to do that sometimes. It's hard to advance in this period of time, but as long as they have good education and they're maintaining and they know what good looks like, I think it's fantastic. Every device, we should not have loss of catheters, although we're getting very creative on IV tubing.
Yeah. Due to people with kidney problems, why would you scan forearm veins? Physicians' paper stated start at the hands with any renal failure patients. What are your thoughts?
Yeah, so in renal failure patients, we do EJs and we do hand IVs, and that's really the only population in which we do those for. Because what we're trying to do is really preserve the upper arms and the forearm anatomy for shunts and grafts to mature over time. We want them to be able to have a mature fistula, and we don't want that one IV or that one stick that we did for that one IV catheter to not allow that patient to have that long term. I'm talking years of therapy. So in that patient population, that is the exception to the hand rule, but we really should still not have them in a hand area where they're flexing. That's good. I'm glad you read those guidelines there, and there's a new edition. So
this one's about 22 gauge PIVs.
Yeah.
If you need an emergency drug, this will blow the vein or limit the rate in the emergency to administer.
Yeah, so the 22 gauge actually is the most common size peripheral IV used in the world, and it's because in pre-op, that is what they use a lot for induction. In the ICU, in the critical care patient population, you can limit volume infusion. So I'm not saying put a 22 in the ICU patient that needs volume resuscitation, but we should not do 18s or 16s routinely due to the damage that causes from taking up too much of the vessel. So we really have to think smart. And remember too, I always say that when we change sizes of the gauge, a 22, because if it's intended for a smaller body habitus, it's a shorter polyurethane. So you really have to make sure that you have enough catheter to get into the vessel and remain. That may be why those are blowing too. So always make sure that it's not just gauge, it's also length that's required. A 22, longer 22 may be fine, but it's the shortness of the catheter.
And this is a follow-up on the PIV issue. And this one's from Jack, our friend Jack Ledun, another Herbst Award with you. He's talking about continuous infusion of Vesicant meds. The recommendation was not to administer via PIV. He'd like you to speak to the practice of vasopressor infusion, definitely vesicant via PIVs.
Yeah, so we know that vesicant and irritants are given in the emergency situation. And we know that in the emergency room or in the ICU, when you're saving a patient's life, you're absolutely going to give that 1 dose, 2 dose. But I'm talking about long-term infusion of vesicant irritants known. And those drugs specifically that I'm discussing, such as amiodarone and others, on the IFU of the product. Remember, you always should go back to the instructions for use. The instruction for use of the product is actually advocating that as well. Yes, you can give it, but as a long-term option, you should really give it through a central venous access device.
So this is an interesting one here. So it seems like conflicting information. They wanted some clarification, and they're saying less than 45% catheter to vein ratio. Why not 33%? INS is based on one study. Gavaselt recommends 33% max. What are your thoughts?
Oh, so this is the deal. The 33% was based on one study. The 45 was based on one study. And I think as vascular access specialist, whatever you choose to use, you should document it and you should measure every time and you should set your own criteria. Because when you implement a practice in your hospital, you benchmark to what you did before and you benchmark to how you've made a change. So as long as you're sticking with 33, because it's easy to calculate, or 45, because that's what INS is saying to do, then as long as your entire team is doing the same thing, your patient, the outcome thought process, all your patients are getting the same attention to detail. So the team should stick to one, the entire team. So I don't have a rationale as to why INS went to 45%. More research needs to be done. And by the way, the 45% publication was all human people. We are healthy human people. We wouldn't put a PIC in a healthy human person that didn't need therapy. Because remember, when we're sick, the body responds differently. The intima responds differently. The volume concentration responds differently. And by the way, all of those were volunteers, just healthy volunteers. So we need more evidence in the catheter to vessel ratio.
But they also talked about the inflammatory state, and any patient that we're getting a PIC in is inflammatory. They're by definition. Then if they're diabetic and they have cancer, it just tops it. So that's worst case scenario if you've got zero else to do. In my opinion.
So remember though, this is the other thing that you have to do. You also have to take some of the guidelines and you have to mold them, right? So it says less than 45%. That really should be your worst case scenario, because it also says use the smallest catheter in the biggest vessel. So that 45% really should be your worst case scenario. And there's tools out there to help you identify what percent you're taking up when you put that size catheter in. So
true.
More research. So if anybody on the call is doing research, please, please, please continue. We need oncology patients in that. We need trauma patients, because the body habitus responds differently in those critical scenarios.
100%. So PIV is inserted in an arm that has a humerus fracture in the last couple weeks. What are your thoughts? Can it be inserted into a current fracture?
So there isn't a, if you ask me about the IO, I would say yes, but if IV, I can't say that you can't. I don't think there's literature to state that you can't. Gosh, if the patient lets you near them, and if that's the only side. Now, would I, this is my vascular access thought about it. If it's broken, I'm going to sling it. If I sling it, I'm going to baby it. If I baby it, it's going to swell. If I put an IV in it, it's going to swell. It's going to give me negative thoughts about my performance of my catheter. I would put it in an active range of motion arm and not put it somewhere where we're going to baby the arm to make it look like we're contributing to a negative outcome. That would be my only thought. You can take it the other way though, Judy, and say they're not going to move, so the IV is going to stay forever, but that may be the rarer side, depending on what you're infusing.
Yeah, if there's a better choice, there's a better choice.
Yeah, agreed.
What about device selection apps? I know we kind of mentioned that earlier. Is there any that you recommend for the audience?
So Magic is a good one. The Vessel Health and Preservation book that Nancy Moreau authored and colleagues has great. If you don't have that, that's open access resource. It has great device selection. Improved PIC website has a lot from Vineet Chopra's and his group there. It gives you every tool. The I Decide tool from Australia, that's a fantastic tool. Like you need to, to think we needed all these tools, we did. We needed it to better standardize how our team reacts to situations. So there's several tools out there. If you type in device decision tree, vascular access, or the Gavicell also has an app on the phone. So there's several apps that you can download for free, and they're all evidence-based.
Okay, here's one.
Take a look at it from like length of therapy and what kind of medication or infusate you're putting through the device. Is there a good source for clinicians to look at as far as like which drugs go through central lines versus midlines and peripheral IVs?
Yeah, so I would ask two things. One, on the INS website, when they took pH off and they added osmolarity to increased it to 900 milliosmoles, they actually had a vesicant irritant task force created. And this task force identified all of the medications that have published negative outcomes. So please reference that. It's on INS or ins1.org. It's freely available to you, and it has the list of medications. And then what I would do with that list, I'm looking for it on my desk because I normally have it. I would take that to the pharmacy in your hospital, and I would say, how many of these do we use? And in what units do we use these the most? Because that'll help your team identify what the risk of your catheter surviving once you put it in and walk away. So really work with pharmacy should really be an intricate part of the teams.
Here's one, it's a demo for you.
Okay.
I love this. Placing a PIC in a patient that's prone. Our asker would like you to show us, demonstrate how that could be done. So with that, black down.
So, yeah, so you're this way, right? So the patient is positioned like this.
Yes.
So you're actually going to come from the back side of the arm, but you're going to come through the basilic. You're going to have access to it. My thought process here is this may become more of a standard thing than we think of it today. And as long as you can get to the upper portion of the arm and you can do RAPIVA, which is the rapid assessment of peripheral anatomy, and make sure that the vascular is patent, and that you have a big enough vessel, because this is the concern with proning and placing a PIC, is if the patient doesn't have adequate blood flow. And then we know now that they're clotting faster, they're having hematology changes, they're requiring heparin or prophylaxis for decrease in DVT. If you place a catheter and you place a catheter in too tight of a structure, you're definitely going to have a potential negative outcome. And if you use tip location technology, and that's probably the only time I would prone and put a PIC in, because you can actually see and you're navigating at the same time as that PIC's coming in place. Otherwise, you have to have an x-ray machine come in the room, you have to have multiple other facets, and it may take away the benefit of you just putting that PIC in a prone patient and being able to clear it for use. You definitely can't put a central line in the neck or chest when the patient's prone. So that's really your option. You can femorally place a tunneled catheter through the groin, also feed it up and use tip location technology. Otherwise, you'd have to coordinate with multiple units, to even get an x-ray to try to clear the line after you've put it in a prone patient.
So if a patient has a pacemaker, you would recommend no PIC at all, or use the opposite extremity?
Okay, now this question comes up all the time. So removing a PIC on a pacemaker side is more important than inserting a PIC. Some people say, some of the papers will say, or your interventional radiology department. So this is the first thing. What does your radiology department say? Because they have to fix the problem if you break it. Okay, so that's just one thing. How fresh is the pacemaker? Is it brand new? The wires were just seated and they just got out of interventional radiology? Then I would use the opposite side. But remember, the SVC and the circulatory system, that's all the same place. Regardless, if you put your PIC in the right position, you're going to be close to where those wires are, whether you're on the right or the left side. So you really need to clear that through radiology to make sure that you have a plan just in case. I think historically we've always said send them to radiology, but I don't think we have to.
Yeah, I've heard it like placing PICC lines on the opposite side of a pacemaker.
Yeah. And sometimes that's because of where the pacemaker is put in under the chest, and it's pain, it's other things. It doesn't necessarily mean that because the wires, you're going to impact the wires differently coming from the left or the right.
Yeah.
True. Should we place a midline on a patient with positive blood cultures?
You guys. So catheter insertion is not a strategy to reduce an existing infection, or it doesn't remove an infection the patient currently has, right? So we shouldn't do it as a risk reduction to reduce infection or to treat the infection. If you have, did you say get positive blood cultures from midline, or place one after positive blood cultures?
If they have positive blood cultures.
So if they have positive blood cultures, your hospital policy should dictate the time period in which you have to wait to place the new device, because remember, a midline is, you're better off placing a short peripheral IV and getting clear blood cultures and then putting the next device in. The more invasive the device is, the more risky it is to the patient, and we're going to infect the new device. So infect a cheaper, smaller device if that's what you're going to do. You can remove, you need access to give the antibiotic required to treat the infection, so a short peripheral IV, and then reinsert for the long haul. So I would not place a midline on a patient with positive blood cultures, and that should be dictated by your policy, not by a webinar.
I mean, we're looking at big vessels we're inserting these lines into, and really like catheter related bloodstream infections. When we look at these globally for all devices,
yeah,
you're still putting a line in the vasculature. There's still blood culture positive. We just have to weigh the benefits with the risks.
Yeah, you put the least risky catheter in. So if the antibiotic that's going to be given is not a vesicant irritant, then that patient can simply have a short peripheral IV. Once the blood cultures are cleared, then, and the patient needs long-term therapy, still requires long-term therapy, then you place the next device. But just know that the hemogenous seeding that occurs when you have an infection, the body doesn't differentiate between dirty and clean blood. Everything gets infected. So the least amount of plastic in the body is the best in that scenario. And if you can give oral medications, give oral.
Say an interesting follow-up would be like, is anyone placing IJ PICC lines?
It's in the neck, it's not a PICC. You can't put a tourniquet.
Yeah, so is anybody placing an IJ PICC line? So let me just go through my definition. So an internal jugular catheter is a central venous catheter. A PICC, if they say PICC, by nature it's peripherally inserted central catheter. So they would be using a product what we consider off-label. Are they doing it? I believe there's some literature saying that in some countries where they don't have access to multiple types of products, that they are getting creative. But that would be considered off-label use, unless the product is indicated for it.
I think the point is, though, some people still don't, I don't think, understand that across the country, there's many non-physicians placing central venous catheters. So I know Vanderbilt's had a program for a long time. In California, I used to place central lines as an RN. There's in Arizona, where you started out, there's a whole group of RTs and RNs placing central venous access. So across the country, tons of us. So yes, absolutely. There's great training to be had. Don't just start sticking them because other people do that.
Yeah, if you don't have the length that you need, or you don't have the lumen configuration that you need, or you don't have the size that you need, industry partners are very willing to listen and innovate with the clinicians. I think about some of our ultrasound companies. We ask for it, they make it, because they know that they're trying to fit the need. You may have something that you need that you don't realize is available because you don't have that. It's safer for you as a clinician and your license and your hospital and your organization to work on label. And working on label means that you use the products based on the instructions for use in the product.
And it looks like this, the question asker kind of sent a follow-up, and she said, I understand the difference between CVCs and PICC lines, I think we're getting at is, but it makes more sense to place these for dialysis patients. And I think the point she's making is like the size of the catheter, maybe. using a smaller catheter than your traditional like IJ central line.
Yeah, and there are smaller catheters. So there are specific catheters like the jugular axillary central catheter that is a small bore, single, double, triple lumen that goes in MST. It goes in just like a PICC would go in the arm, but it goes in the neck that way. For patients with acute kidney dysfunction or patients going home for long-term antibiotics where they don't have any utilization of their arms, right? And I'm glad, Esther, that you're thinking about that, because we should be preserving the anatomy with smaller catheters. So there are some available that do look like PICCs, do feel like PICCs, but they're actually intended and indicated on label for central access. And remember, a PICC is a central line as well. So that's where a little bit of this kind of meshes over each other.
I know we still need to work on a list of definitions and make sure everybody talks the same language. I want everybody to know that we're still going. We're going to go until the end, as long as we can keep Amy here. But if you need to drop off and you want your CE, there's a little box on the side that says handouts. In there, there's a QR code to get to your CE. So you're welcome to. We want you to stay on, keep throwing questions out. We'll keep Amy here till dinner. or more.
It's close to dinner time for me.
Here's one that they want to redo on. So Joanne is asking I believe it was Joanne. Yes. Could you kindly summarize the colors of protected catheters again? It's new information. Thanks.
Okay, so blue is protected at minimum on the outside. So if you look at the hub juncture, because remember in the body, you're when it's in the body, all you see is the lumen that's sticking out unless you're the inserter. So blue means that it's protected. If the catheter is white, it means it's not protected, which really just means that we should have everything employed: education, good aseptic technique, good maximum barrier precautions, good dressing change techniques, and ensure that we're doing good scrub the hub, because there's no interluminal or extraluminal protection on an unprotected catheter. The yellow catheter doesn't have any protection. The purple catheter doesn't have any protection. The black colored catheter has a metallic protection. It is carbon, silver, and platinum on the external surface of the catheter. A brown catheter has an antibiotic protection on it, and a teal catheter, if indicated on the lid stock and packaging, may have an antithrombogenic technology. So there's a lot of different technologies, and these are only on PICCs, only on CVAD type devices. We don't have any protection as of yet on any peripheral, meaning PIVs or arterials.
But there's some PICCs that do have protection. The blue catheters are protected, and also the orangish brown catheters are protected.
Yes. So,
and also green, the teal have some.
Yeah, so I consider that in the CVAD family. So if it's in the CVAD family, the teal, the brown, and the blue, they're all protected in some way. The peripheral IV, though, is what I've said. We don't have anything yet on market for arterial or PIV. And really, if you think about the COVID study, hospital-acquired BSI is really being attributed to PIVs too, because of the manipulation, the insertion, the integrity of the dressings. So something we need to consider.
But there are midlines that are protected.
Yes.
Or so in the PIV family, we have a midline that is protected. So I don't want to ignore that.
But the most common used device is the PIV, and it's not protected, but it is a contributor of other issues. So we just have to make sure that we remove just in case IVs.
Okay, and to follow up on that, it's earlier you stated that the black one was aluminum, but you just clarified that a little bit.
Yes. Carbon, platinum, and silver. Sorry.
Okay. No worries. Well, it looks like Blake fell off here, so we'll go with me. Okay, we're talking about navigation devices. So there's one from BD, and there's a few out there. So do you place, we're going to go with, we're in the Q&A, so we can talk a few brand names and not be biased about it, but do you place Sherlock on the back when inserting in a prone position? I don't know the answer to that, or I try to take a stab at it.
So I don't know the specific answer based on the IFU. So I did see a case scenario, a case study that's probably going to be published where they did do it, and they did it successfully, and it was on a COVID patient. So again, when you're working outside the box, just read the IFU of the product and also your policy and procedure for your hospital. Those two things should help direct you as to do that. But this scenario, it was done that way.
Okay. And there's a follow-up question related to Arrow's product. How do you use that?
It would be done in the same way.
Same manner. Perfect.
Yeah.
Perfect. And then one follow-up, we have Jacqueline Brown. Well, Jacqueline is talking about the Grosjean pick is blue and not protected. We still use, yeah. So thank you for that clarification.
Yes, and the difference there too, Jacqueline, is the silicone versus the polyurethane. So thank you for that clarification. So in the PIC family, because in the coloring slide was really just for CVCs, acute CVCs in the ICU patient population, but in the long-term care, home health, and also in some regions of this country, we still have the valved PIC, which would be blue and silicone in nature, which would not be protected. The hub juncture, though, like the hub juncture of the actual device, will also help clarify that for you, and the IFU.
Thanks.
Kind of on the lines with devices, device selection and purpose. So question here was for oftentimes in different surgeons or oncologists want to use TPN, patient has a port, and then there are clinicians are basically being asked to place PICC lines in addition to the port that's already in place. What are your thoughts on that?
So the first question is why? So do they need more lumens? Is that why? Because they only have a single lumen port? Because if you think about the history of ports, we used to use multiple lumen ports, and we've really transitioned to one single power injectable type of port. And if the patient requires 2 incompatible medications and/or a regimen that requires a vesicant irritant administration, and they only have a single lumen, then it would warrant another device. So it's really, again, based on the criteria of the patient. So we should not avoid using the port, and we should put an additional device in if clinically indicated to do so.
Yeah. And I think I've seen that too clinically, people who go out of state for cancer treatments like Cancer Center of America, places like that, where they're like, don't touch your port, don't let anybody touch your port. And then end up in scenarios where patients are under the belief that they shouldn't allow people to access their port for a purpose other than what they're using it for in their cancer treatment. And then we end up placing a device just like a line in addition to one that's not being used because that's dedicated for their treatment.
In a perfect world, Blake, we would have education and training or a designated team to access a port, just like a difficult Foley team, right? That when we have the confidence within our healthcare organizations that the interaction with the port isn't going to negatively impact the patient, then we will use ports more often. Right now, the oncologists and hematologists are saying, don't use my port because we don't want you to infect my patient. When all actuality is, it's the training required, it's the diligence, it's the consistency that we need to do. And actually, it's the vessel preservation concept too with the patient. But some patients, I'll tell you, they'll say, you can't use my port because my oncologist told me you can't. So once that happens, once that bridge that you walked over that, you have to put another device in because they've been talked into it, which is fine based on probably a prior experience. But hospitals today should have a really good port access plan so that patients don't have to have a second device if not needed.
Yeah.
There's a clarification here. So can you please clarify the black antimicrobial goes by the name Vantex is protected internal and external? Please clarify.
Yes, it is. And it doesn't, so the only difference between the Vantex catheter is Allergon technology actually, and it doesn't have a recommendation as an antimicrobial by any of the agencies. So like CDC, it just doesn't fit that criteria yet.
Okay. And we have quite a few questions on clinical indication, or when to remove based on a time frame. And talking about CVADs and peripheral. So one of them specifically was patient with COVID positive, had a line times 1 week, and clinicians saying, I know I should go change it, but what about IJs and subclavians? And we're also getting that in these questions. I'm trying to bulk for you a little bit. With a midline as well. So talking about a time frame versus the clinical indication. So,
right. So the time frame is I keep going back to the IFU. So the time frame applicable or available to the devices based on the instructions for use. Where we differ a little bit is the peripheral devices where they're clinically indicated. So a short-term peripheral IV where a hospital has determined that they don't do the 72-hour change anymore, and they're going to maintain that device until it's no longer clinically indicated, as long as it's not red, it's not swollen, it's functional, it has blood return, etc., then that is up to the institution. The midline utilization, the central line utilization, and PICC line utilization all have a derived time based on the instructions for use. And if the institution works within that guideline. So I hear actually a lot, Judy, that hospitals exchange central lines after so many days. And I have to remind them that based on the instructions for use and or the technology that they choose to use in their healthcare system, they don't have to do that. And that might actually not contribute to a positive outcome. So we shouldn't be thinking on the same lines between peripheral dwell and CVAD dwell.
Agreed. Agreed. I think there's still some school of thought across the nation that back in the day when some of our more mature doctors possibly went through, we didn't have any blue, different colored catheters. We all had vanilla catheters. And at that point, after 7 days, oftentimes we change out centrally placed lines. Yeah. Now we have protected technology. It's a whole different ballgame, but some of our more learned folks, longer in the tooth type, they don't possibly caught up with that. This is my theory, by the way. I don't have any data on it.
So we've had protected technology for 25 years. How we choose to acknowledge that it's protected, or was it required to be reported for infection, or what the paradigm shift is, may be a little bit different. I do have institutions, because they have training programs, etc. They may change or do something different because of the skill set, the learning. Again, it's based on the hospital's practice and policy as to what their routine normally is. We do encourage them that they extend that out so that they're not causing harm, or maybe the catheter is no longer needed. I mean, the average CVAD, the average central line dwell is 7 days. The average central line will only dwell for 7 days. So do you really have to do that? And how many more days of therapy does the patient need? That should be considered before you change a catheter, regardless of the insertion site. If they need 2 more days, would that change your decision, to change the catheter?
Yeah. What about removal of PICC lines if a DVT develops?
Yeah. So there is a CHEST guideline for this. You can look this up. It's open access. The CHEST guideline says that you should treat the patient, keep the line if still clinically needed, and monitor the patient. If the device is no longer clinically indicated, the patient still should be treated for the DVT. They should also check to make sure that, the tip is in the right position and we're not contributing to the problems with the catheter based on tip position.
This is one for your crystal ball a little bit, but I love the question. This is from Patricia. There's been a lot of talk about PIV infections becoming reportable to CMS. Any idea when? I got my bet. We'll see what yours is.
So I went to APIC and I went to a CDC meeting, and I've been to the reporting bodies thing like 2 years ago. Is it Patricia? Yes. So I just have to say to you, Patricia, and one of my colleagues and I went, and it was in Columbus or Nashville or somewhere. And I sat at this big stadium in the back row, like I was way up high, and all the infection preventionists were in the room. And I raised my hand. I kept it up forever until I couldn't hold it up anymore. So me and my colleague walked down to the front and sat down. And they finally called on me to ask my question. I said, when will PIVs be reportable? And they're like, oh my God. But after that meeting, we've seen more. So we've seen the COVID study. We've seen other of our peer group publications on infection, underreporting of infections. Mackey just did. If you don't have the new Mackey paper on PIV underreported, you need to pull it. I think that what's happening is there's going to be a swell of the evidence. And we also had the CDC and the other body, I can't remember who it was now, I'm sorry, I'm having a brain fart. They actually asked us if we opened up the CLABSI definition and made PIVs reportable, how would that impact your workflow? Shelley DeVries had sent out the link of last year sometime, and everybody responded from the infection prevention area, like how this would work with their workflow. It would change their workflow dramatically, but opening up that definition to bloodstream infection may actually help us reduce the overall HAI, like Kovic's article's recommending. It's coming. As far as I'm thinking, it's coming. And in your hospital today, you're monitoring it already. So you should be able to go to your infection preventionist and say, how many of my bloodstream infections didn't have a central line? And you'll be able to know your rate right there. And that should also, this is a huge topic, probably a separate topic altogether, but you will be able to say, we are safe to go clinically indicated because our BSI rate's this. Because if your BSI rate is really high already for peripheral IVs or BSIs for non-central line patients, which you need to think that's PIV related, if that's the rationale, then, and it's really high, you wouldn't want to go clinically indicated unless you did a lot of education and a lot of awareness and improved that rate first.
Very good. Joanne's coming up with some really good questions too. So we have a couple of you. Oh gosh, Shelley DeVries is texting me a little bit.
Hey,
Shell. Oh gosh, she's not sure that most people have an idea what their BSI is with peripherals. So
yeah. So I don't think the general public does, Shell, for sure. I think that when they're capturing it, depending on who they are, they may be skirting it because they don't have to look and do a deep dive because they don't have a central line. But I think it's obtainable. I think you can garner the information if there's an interest to do so. And hopefully that interest doesn't come after it's required. Hopefully that interest comes proactively.
Yes, ma'am.
Can you explain what one would look for under ultrasound when we're looking at a patient's arm with a midline that's not drawing blood?
Sparkle.
Sure. So you're going to scan to the arm. You're going to scan to the tip. So if you use a 15 centimeter midline and that's what's documented on your patient documentation, you're going to take a measuring tape from the insertion area up to where the tip of the catheter would be, and then you're going to scan the vessel. So just like insertion, when you look for that vessel to collapse during compression of the ultrasound, you're actually going to look for the tip inside the vessel, and you're going to look to see if there's free flowing blood around the tip of the catheter. Because what will happen if you gave a medication and the medication set at the tip of the catheter and it caused intima damage or intima hyperplasia, it would reduce the total flow. So you'll be able to see that on ultrasound, especially in your larger vessels. There's actually a really good on Teleflex Academy. I think you're going to show the link to Teleflex Academy. On Teleflex Academy, there's a really good vessel health and preservation module that actually walks you through cell damage of the intima during medication administration. So it will really show you in a 3D what that might look like under ultrasound.
Some really great resources on AVA Academy.
That's Teleflex Academy as well. And
Yeah,
should be showing, but I'm having huge technical issues with my computers. I'm lucky to have a server right now. But the folks, you can go to teleflex-academy.com, and I'm going to try to get this because I thought it was showing now, which obviously not. But keep going. We still have almost 300 people on.
I know, it's 2 hours. We're 2 hours in. I think we had a little bit technical difficulty, but 2 hours.
Yeah, we did. Okay, let's talk about this one. Your thoughts on using deep vein access catheters versus a PICC or a regular shorty?
The shorty. So the only thing is there, we really have to consider that if the vessel is greater than 2 centimeters in depth, that you really need to do more of a polyurethane, more flexible type catheter, such as a mini midline, or and if you just think about the insertion, right? The insertion to a deeper anatomy, as soon as you get into the deep anatomy and then you try to advance the catheter, that actually holds the bend. The polyurethane type catheter that's an IV type catheter holds the bend in shape, and you can't unbend it once it's bent. So if you go greater than 2 centimeters, you really want to use a normal MST type midline catheter. Or a long IV catheter, you know, something longer that resembles a midline catheter. Did that answer the question?
Yeah. No, I think that's perfect. When it comes to peripheral IVs, we change them as per clinically indicated. How is this looking at in regards to midlines?
So midlines have a dwell of up to 30 days depending on the manufacturer. So again, read your instructions for use of what you use. You may get close to that time period. You may require a couple more days than that, and that's again up to the hospital as to whether they're going to change or rotate that midline. If you have a midline still performing at 28 days and need 2 more days of antibiotics, and that still considered within the use period. Some hospitals have extended all catheters to clinically indicated. Again, we can only make specific recommendations from a manufacturer perspective on an IFU, and then you have to adopt those to your practice within your institution. And sometimes you have to take the risk benefit of the customer into account as well, or to the patient, because you're sticking them again. So I'll give you the scenario. I was in a hospital. They were using a midline, and it was at the 30-day mark. The lady needed 2 more days of antibiotics, and they changed the midline. Yes. Was that what everybody would do? I don't think that's what everybody would do. So monitor your midlines for performance, and at least set some kind of criteria as what your assessment criteria is: redness, swelling, drainage, blood return, etc. And then you're going to make those determinations. I see that peripheral access in general will go clinically indicated as it's allowed to do that.
Let's see here. Interesting one here. So, hi Amy, my name is Rob. I'm a clinical specialist with Ethicon BioPatch, and worked as getting right now, and have worked as an ICU nurse with Matt O's hospital.
Yes.
My question is, what trends are you seeing in the use of PA catheters across the country? Do the risks outweigh the benefits, especially when CVP is an option? This is something I've heard mixed answers from providers.
Yeah. So thanks, Matt, for the question. So pulmonary artery catheters or thermodilution catheters are used in your most critically ill patient who needs cardiac measurements and monitoring, meaning they had open heart surgery, maybe they had a transplant, maybe they had a lot of myocardial dysfunction and they had a long surgery. In general, the trend is, and what the literature is showing, due to the non-invasive capabilities, a lot of that is either non-invasive. So if you see one, it's needed, it's required, but they're still having the sheath, right? They may still have the sheath in, they may still have the access, and you can definitely get CVP monitoring and other non-invasive measurements based on those parameters and blood pressure and heart rate through other modalities. So you may see less of those. In cardiac centers, you're still going to see PA catheters.
Yeah.
But in vascular access specialists should be familiar with PA catheters. Again, it's another source, it's another lumen, it's another troubleshooting question you may get over time. So definitely thanks for that question, Matt.
I was going to say, when it comes to PA catheters, I see a lot of people talking about going with like diastolic pressures instead of wedging, just because of the risk of wedging the catheter. And it's interesting, like you mentioned too, like when you have a cordis in place, I saw another question about leaving a cordis in place, inserting a slick or something like that, where you can get a catheter tip that terminates in the distal SVC with those kinds of cortices. So there's a lot of, when you're done using a line, just like PICS or other central lines, if you're done with the PA component, remove the PA catheter, you still have an access point, and you still have some options as far as what you can do with it.
Yeah, so just remember, there's multiple catheters that are called multiple access catheters or multi-access catheters. They allow for another product to be placed through them. So whether it's a transvenous pacer or whether it's a PA catheter, etc. And it allows for that monitoring when needed, but removal when no longer needed. And then you can either, add additional lumens if required. There's just so many different feasibilities that you can do. The thing is, if truly the catheter or the componentry isn't required, we're doing the right thing by removing that component, but maintaining access in patients who require it.
Perfect. Well, our friend Laura, our mutual friend Laura, asks us, when proning patients during COVID-19, how do you manage continuous infusions without catheter migration or dislodgement?
Yeah, I don't know that we can say we effectively do that yet, because I don't think enough patients have been prone to measure, and I don't know that people are discussing catheter loss. But what we can do in hospitals is maintain securement, make sure that we have confidence in the securement that we're using, make sure that the dressing is intact and that we're using, make sure that you have enough team members to prone the patient when you're rotating. Because, I've proned many times, and it takes 10 people or a proning bed, and most people don't have the proning bed. So it takes a village. Somebody has the airway, somebody has the vascular access, somebody has the tubing, somebody has the legs, and everybody prones at once. It's a big undertaking. So I think, one, having really good securement that we have confidence in, Laura, but also having somebody dedicated to those lines when the proning is actually taking place. We lose a lot of lines in patient positioning. Just sitting patients up, we lose lines. So having all of that key focus and understanding, we simulate proning now, right? And in centers all around, they're simulating how to prone, because that's how risky it is if you're not normally proning patients.
It's a lot of effort, and there's a lot of lines and tubes and drains that easily dislodge.
But the evidence right now has pretty good outcomes, so we can't knock the evidence. So remember what I said earlier in the lecture, is that on Google Scholar, if you go to Google Scholar, and then on the bottom of Google Scholar, it has there's about 12 academic journals that are providing any COVID information open access. Click on any of those journals and put in your search topic, and it's phenomenal. You can look at proning, you can look at statistics, you can look at a lot of these things. And then INS also came out with some statements around the extended tubing and tubing being draped, because that's how it has to be. So I think we have to be careful to pass judgment on some of these things when we're not in that hospital or in that scenario. So we just have to really, be open-minded to some of the things that are happening right now, and work within our directions within our institutions.
True. To live a day in your shoes.
Yeah.
Let's see. Ports for infusing chemo, and the question is, if you're not getting adequate blood return but the port flushes easily, there's no symptoms other than basically the assessment of the line's patency, and the doctor says it's okay, do you use the port?
So there are guidelines around this for the Oncology Association, which is to infuse a vesicant irritant such as a chemo agent, you have to get blood return. So this is why those ports may be snared in interventional radiology. And what I mean by snaring is the lumen, they go up with a wire and they pull the fibrin sheath or whatever might be in the way of blood return. There's definitely literature on cases where there wasn't blood return and it had a bad outcome. So it is their guidance that the port that you're going to give a chemotherapy agent through has a blood return.
Oh, this is a great one. Many of the lines have, they claim 30-day protection on the protection of lines. Is 30 days the longest protection that they give?
It depends on the technology. I would have to say that you have to go back to your instructions for use, because not all products are made the same. And in the indications, it will clearly tell you how and why and how long the product is indicated with the protection. Now, you may be able to use the product further than that, but that is the amount in which the catheter would be protected. There's several on the market, so you really have to research each of those. There's inside protection, there's outside protection, there's antimicrobial, there's antibiotic. So you really want to do some research on those, especially if that's part of your CLABSI reduction strategy in your facilities.
Very good. Now, earlier you said I'm not sure because blue line, it was stated that blue lines have both. Sorry, I don't have the whole question in front of me, but they only have chlorhexidine, correct? Question mark.
No. So it depends on the manufacturer, it depends on the generation of the technology. So for example, Teleflex has 3 generations of technology, and one of them only has chlorhexidine, and two of them have chlorhexidine and silver sulfadiazide. So you really have to identify what you're using in your facility and how you're using it. Multiple products have multiple different types, and generations matter based on the protection and the indications for use.
Thank you.
Yeah, so I know I've seen some apps out there, but any resources you might recommend as far as how to calculate easily catheter to vein ratio?
I think your husband has one.
Yeah, there's an app. So CR Calc.
Free too, right?
The app is CVR Calc, and that is an app for calculating catheter vessel ratio. There's definitely a few tools out there. Your ultrasound machines, if they are up to have new software, many of your ultrasound machines do it. Some of your ultrasound machines, you drag the catheter size into the anatomy and it tells you. And some of them are based on area, and some of them are based on circumference. So yeah, there's some options out there for you. But my recommendation really is that whatever option you decide on, that your whole team uses the same option, so that every patient, again, is measured the same, uses the same scenario-based tool, and you can report your metrics based on the use of that same tool.
We have a couple questions about the CE code. So the QR code, if you haven't used it before, when you aim your camera at it, it automatically links you. So then you just say, yes, I want you to take me to that form. So I know we haven't used them for the longest time. So if you have a problem after that, aiming your camera at it, and it doesn't work, you can always email Ava ED, so for Ava Education, Ava ED at avainfo.org, and we'll get back to you. Because Blake loves those.
I do love them, and you guys will get an automated email once the webinar closes. So once obviously we're past the time that it's scheduled for, but when we actually finish the webinar an hour after, you'll get a link to take that too if you're having issues. So.
This one's going to make you cringe a little bit, Amy, but what do you think of a hospital system?
You're going to ask it anyway.
Yeah, I am, because it makes it's even more fun. So what do you think of a hospital system that uses the Aero VPS technology, but then also uses a post-insertion X-ray after 2 years?
Yeah. So I'm not going to cringe here, because I think that that's a reality. And I think that when we go in as vascular access specialists and we implement something to make a change, we all should understand what that change is going to be, and there should be some kind of consistent how many of what we're going to do to say we have confidence in this, what's the protocol going to be. There are scenarios where you're still always going to have to do an X-ray. But in the majority, when you purchase tip location technology, regardless of what who your manufacturer is, the goal is to, if indicated, to eliminate X-ray, eliminate that exposure to radiation, eliminate the time and steps. When you don't have that camaraderie as to what the plan's going to be and how long that initiative is going to take, sometimes that's where you fall out. And then again, you still always are going to have patients that you have to X-ray. So I don't know that any hospital will ever be able to 100% remove X-ray, because there are scenarios that may require it.
True. true.
But
I
it
actually
shouldn't
know
be.
another system that took 6 years to clear.
Yeah, yeah. I
So,
was gonna
I
say,
mean,
Judy,
it takes a long
what was
time.
your years? Yeah.
Yeah, I mean, it takes a long time.
Yeah, if part of the compelling option is for you, that messaging when you implement is to remove, eliminate X-ray, cost savings, radiation exposure, that should be part of the continued messaging as you do those things.
Right.
Sometimes we get lost in that a little bit.
We're getting down to it. We only have about 10 more questions for you.
Oh my
Look at
goodness.
this.
Thoughts on mid-thigh pick placement? Where do you get trained?
So there are a couple clinicians that are doing mid-thigh. Matt Ostroff in New Jersey is really an advocate. We did a tunneling session at AVA conference in 2019. We're going to do it again in 2020. So there's options for training. I think you have to have a good proctor at your facility. I think they have to understand your skill and scope. And I think you have to have the patient population that requires it, because not all patients are going to require this type of approach.
Do you consider the utilization of tissue adhesive at the insertion site a tool for helping infection prevention?
Is it, so I do believe the tissue adhesive that's on the market today is indicated, has an indication on its use for it. So if the IFU for the product has an indication for it, you should implement and measure, but you should also have a baseline measurement of what you had before, because you're really looking at exit site management. So clean and dry intact dressings, dressing disruption, dressing changes on an uncycled pattern. All of those have evidence to support that they have a negative outcome to the insertion site. So if you use tissue adhesive, you may be able to show a reduction there. But if you're doing it, please publish or do a poster at AVA and share that, because I think the biggest contributor is the dressing disruption.
Yeah,
That's my opinion. That's my opinion.
And then, and true. There's I think a lot of the companies that we've talked about securement and we've talked about site care. Go on their website and look at some of their the data.
Yeah. We're all one vascular world, so and the world's pretty small. So.
Since we're talking about care and maintenance topics as well, let's dive into this one. Hypercoagulable state seen in COVID-19.
Yeah.
And really, what do you feel about heparin installation as a regular therapy versus TPA preventatively? I would say, I mean, for me, TPA is usually after the fact. You have the clot, you got to break it.
Yeah. So this one is really, we used to do heparin, right? We used to do hep blocks, and we took that away because we just didn't think that was required anymore as a blanket therapy, meaning that we didn't need it for everybody, but there may be clinical scenarios where we do. And those clinical scenarios are where we have high platelets, sluggish lines, reocclusions. So hep block is probably the least invasive and the most economical. TPA really is cost, it's expensive. Who can do it? Who's trained? Does it dwell in the lumen? There's other requirements there. Again, looking at the product IFU. The third option really is to try an antimicrobial, or not an antimicrobial, an antithrombogenic type property catheter, to see if the catheter technology says no adherence of fibrin or formation or clot to the exterior surface of the body, actually does that in the COVID patient. So you really have to think of all of those options. I think we want to go to pharmaceutical first because it's easy. It's expensive though, especially if you start thinking about declotting daily. Check your tip location. Is it correct? Is the catheter too big for the insertion site? Those things matter as well.
So to request, can we get a copy of the basic device selection tool? And do you have a removal algorithm?
Yeah, it's funny. I did a lecture for one of the AVA networks, and just know that, we did this lecture today because this is a lecture available on Teleflex Academy, and it's recorded on Teleflex Academy, but it's also something available for the networks. But we, since we're not able to do the networks, we're providing this. So that is available there. You can definitely resource and pull that from Teleflex Academy. We can provide that. And what was the second question, Judy? Algorithm.
The algorithm. The algorithm that you showed?
Oh, backwards. Sorry. So I did a lecture for, I did a lecture for Conavan, I think, in San Francisco at the Big Kahuna or Big Kona lecture. It was device selection backwards. So if you take the device selection tree that I gave you and you just turn it backwards, it actually gives you the, do this, don't do that, do this, don't do that. I'm happy to share that offline with you.
Perfect.
It would be it's a personal share.
Personal.
And really it should be when no longer clinically indicated. That's really how it should be done.
Let's see, intermittent irritant medications infused via a peripheral IV results in infiltration and phlebitis in many veins in many patients. Vancomycin and even IV Rocephin are examples that should not be used long-term via short peripheral catheters under the clinically removable protocol. Sure. Patient-centered clinical thinking is needed, and a midline is also not a high dilution vein area. And then it looks like frequent site rotation in difficult access patients leads to what choice for a 2 to 4 week therapy?
Yep. I feel your pain. I don't know whose story you're reading there, but so this is what normally happens. So we put the IV in. They may or may not have been a difficult stick. They get their first dose of antibiotic or Rocephin, Vanco, whatever it is. Maybe it's considered a vesicant irritant based on the dosage or the strength, right? And then you get called back within 4 hours, 8 hours, 6 hours. When that next dose is due, it's funny because it's when the next dose is due that you get called back. So because we're the inserter and not the giver, sometimes we don't see those problems or complications occurring as frequently as we should. So what you just described was very true. We rotate, we move, we rotate sites, we move, and it's just because we're not synthesizing the fact that we're giving it and it's causing harm. We're giving it and it's causing harm. So 2 things. One, you really want to work with pharmacy to make sure that the concentration of those medications is suitable for peripheral access. And if it's not suitable for peripheral access, that the patient does have a CVAD placed. Sometimes pharmacy can help with that though, to minimize the risk. There's also potential flushing that can occur. It all depends on the dilution of the patient. Remember that more extremely old the patient is, potentially the smaller the anatomy is, potentially the worse or quicker you'll see signs and symptoms when you give something that shouldn't be given peripherally. So you really should see that earlier than exhaust everything and then place a CVAD.
So we have Steve asking, or saying, Pittaruni is recommending femoral CVC or PIC in dyspneic COVID patients and to avoid the neck or chest. I'm not quite understanding it. Sorry, I'm reading. I should have reread it.
Yeah, so I've read the guidelines, so I can answer that. So it's because that's where we can gain access and we're proning them. Because in Italy, if you look at the number of cases and the number of deaths, they're doing a lot of proning, and we can't manage as much in the neck or chest potentially as we can in his patient population that he's describing in his COVID scenario. So the other rationale here really is, if you think about it from a body habitus stature, if the plan is to prone them, you want the catheter in the biggest potential vessel, and that is coming from the groin. Because the upper body, the torso, the lungs that are hyperextended and inflated, being ventilated, and now you're prone, the swelling and the third spacing and that response that happens when you flip a patient that's being volume resuscitated on top of being prone could cause a lot of compression. So I think that if I'm reading into Dr. Pittarudi, I think it's because it allows for the most hemodilution around the catheter body.
Yeah, I misread what it said. I read this paper a few times too. I'm a little confused with the question, so sorry about that. Okay, I think we're almost down to it. Amy, we have 2 left.
Okay.
You might get to go to the bathroom today.
Right.
It's like on the floor.
So 50%, and this is more like a commentary, I think, and then a question at the end. So about 50% of ICU patients are ARDS, and about a quarter of them are sepsis. How many central venous lumens do each group require? I think it really kind of answers itself, but go ahead, Amy.
Yeah, so the standard in the intensive care unit, the standard I would say is a triple lumen central line, right? But that's not the same for every single person. You may need a double lumen large bore line. You may need a double lumen in an IV catheter. That's not really a question we can answer. How much are they on? Are they on vasopressors? Are they on everybody needs nutrition after, so many hours. Like, what else are they really getting? That's a hard question to answer because I'm not in your scenario. And in a perfect world, would we put one device in that had all the number of lumens? Yes, but then what happens when we start to titrate and remove therapies, and then you have a bunch of just in case lumens? So I think each of those scenarios is different. I think in your hospital, what you should do is try to standardize to what the minimum the things that the patient gets, and then add as you need therapies, and then remove when no longer clinically indicated. And I say that a lot, but we have a lot of opportunity to remove, IVs that are put in places that we didn't even realize they're in, or arterial lines when you don't need them for weaning the patient anymore. All of those definitely at risk.
True.
And it really boils down to what that patient needs at the time.
Yeah. Yeah.
And it's hard to predict too, because if someone's clinical course changes, or they get sicker or they get better, having a just in case in a triple is handy if you're predicting a worsening clinical outcome, but again, that just in case line, we kind of talk about how do we eliminate that? And I don't think it's ever going to be a perfect world.
Yeah.
But the more lumens you add, the more risk you get for infection. And it's very
and remember, we are an adjunct, right? We may not be the provider of the patient. So when you go in and the primary nurse says, I need 5 lumens, and you're like, no, you're only going to get 3, that doesn't go over well. So really being, especially in the intensive care unit, really being a collaborative partner to identify the risk benefit. And sometimes it's a lot of education that we end up providing, because they are so regimented on fixing the now. They don't, it's not about 2 days from now, because right now I'm saving a life. So that has to come into your rationale too. All these algorithms are great, but when you're saving a life, it might not fit the algorithm. So we just have to keep that in mind.
True. And then I think one of the most underutilized devices is the IO.
Yeah.
Too. I mean, we're not looking at IOs.
Yeah, for sure. And you know what? The thing about the IO, proximal humerus insertion, quick, no ultrasound. You don't have to find that person that can do that device or that line and have that delay in care. I think it's underutilized, Judy. But the other thing is, if it's inserted, pre-hospital or ER and then comes to the ICU, sometimes the vascular access teams are the ones that actually have to help educate on that, or maybe they have to remove it when they have another device put in, or maybe they have to put a second one in because they have 2 incompatible medications. So True. Each of these pieces should be in the toolbox or in the forefront. We didn't ask that actually on the polling questions, but there's a lot of teams that have IO in their top cart for this very reason.
Well, yeah. Okay, we're down to the last one, and for the 200 of you that have stayed put, oh wait, another one just came in. Tim didn't want us to quit yet. Thank you so much in advance. So this one, Jamie has been waiting forever for her question, so we're going to go through it.
Okay.
I noticed with COVID patients, the veins seem non-compressible and are not getting immediate blood return when inserting the needle into the vein. Any advice or guidance on this?
Yeah, Jamie. So we're reading that too. So there's some good articles. I wrote one down, so I'm just gonna look at my notes here for you. So Dr. Bincho did a good article on endothelial damage leading to cell disruption, even for vascular access, any type of device that's going in for the COVID type patient. So what they're seeing is a lot of stasis, not a lot of blood movement, not a lot of blood flow. Remember, the first line of medication is neosynephrine. So they're trying to, and levofed, if you think of that term, they're trying to constrict them so that they circulate the trunk. And sometimes when you do that, you have less blood flow in the periphery. So if you're looking at the peripheries, that definitely could be an issue. The venous distension could just be because there's a central thrombosis, potentially the neck or chest, or maybe there's pressure due to ventilation and you're not having the good blood flow, and then it's going back down the arms slightly. I definitely would avoid some of those areas, and that patient probably needs central access or femoral access, not anything in the periphery. If you can't compress, you have to automatically think thrombosis or high risk of thrombosis. We're also seeing a lot of really black blood, and that's, whether it's hypoxemia or the inability for the binding of the oxygen. There's a lot going on there. So on that Google Scholar, there's so many resources. So please look your topics up there.
Okay, Blake, you want to take us out? Tim had one more coming in.
All right, we'll take this last question here. Should we be avoiding PICC midline placement in COVID-19 patients, especially if they just hard stick? I had to question such an order this morning because the lab had been having issues getting blood draws, and they asked for a repeat draw because the WBC had dropped by 70% over 48 hours, and they claimed the lab was skewed and demanded another draw. And that was after 45 minutes in the room with the patient.
Yeah.
Are we correct to limit exposure in these patients?
Yeah. So I think it's important to understand that each scenario, you just described a very unique scenario where the blood was sent to the lab, they didn't believe the reading, and because it took so long for them to get blood, now they're going to ask you to go in and put a line in so that it's more convenient, which in patient scenarios with difficult venous access, that may be totally appropriate. Midlines and PICC lines, central lines in COVID patients really depends on the care continuum in which they are. If they're acute, the volume resuscitation, and they have uncollapsible anatomy, that's probably not a good PICC or midline patient. That would probably be more of a central. If they're a COVID patient and they don't have good vascular access, they're going to need some type of device. So if the blood draw is a sign that they actually need some kind of device, because they're going to get fluids and they're going to get antibiotics. They're not just going to, they're treating these patients. So I don't think it's a bad idea to have a device. I think it should be well planned. It should be strategic. Everything should be done at the same time if possible. And after the device goes in, get that blood so that they don't have to come back in, and you're helping your other coworkers. There should be an indication besides a blood draw for a vascular access device though, especially a PICC or a central line.
Agreed. Well, Amy, this was amazing. You're such a good speaker. Thank you. It was fun.
You're welcome. Remember to look at your IFUs of your products that you use in your institutions. And this is what I always say in my closing. I always say, that menu drawer that you have, we all have one. All of our departments, we have a drawer that has all the menus for the takeout food. Every single product that you use should have the IFU. You should have an IFU for every product in your menu drawer, just like you have the menus for the restaurants.
Absolutely. Well, everybody that hung in there, thank you. You guys are awesome. And we'll see you at our next webinar. Thank you. Thanks, Aim.
Thank you. Bye.